Hello again. Welcome back to part 2 of the Gaps in Knowledge from the AKT-1 at the Robert Wood Johnson Medical School Anesthesia Department. This test was taken a few weeks back by our CA1 class, and this is a collection of some of the most missed keywords from that exam. So please watch, enjoy, and I hope you learned something. Okay, the first keyword of part 2 is Rocuronium elimination. Now I created the image over here on the right with a big picture of the liver and a big bottle of Rocuronium smack in the middle of the liver because the liver and biliary system is responsible for the vast majority of elimination of Rocuronium. It's 90% eliminated in the liver and biliary system. And actually, a very small amount of the Rocuronium molecule is actually metabolized. Now, the kidneys are responsible for about the other 10% of elimination, but by and large, the liver and biliary system is mostly responsible. Now, in patients with liver and renal impairment, the elimination time may slightly be prolonged. But clinically, there's a relatively insignificant increase in the duration of action. So we often see doing kidney transplants and patients with renal failure. We talk about, or we think about Rocuronium or the use of different muscle relaxants. In practice, this may not be quite as clinically significant as we believe. Our next keyword here is single breath induction. This is a topic that is often tested in peds, but you need to understand the pharmacology of the agents that are being used for single breath induction as well. So ultimately, this is usually used, or most effectively used rather, in a cooperative child. How this is done is that the sevoflurane is turned to a maximum of 8% all the way up. The practitioner should instruct the child to take in one very, very deep breath of the 8% sevo and hold their breath as long as possible. And adding nitrous oxide to this 8% sevo may hasten the effect due to the second gas effect. In general, it's pretty well tolerated. Sevoflurane has a non-pungent odor. It's sort of pleasant, actually. And so a cooperative child generally tolerates that part well. It also has a low blood gas partition coefficient, meaning that it is relatively insoluble in blood. For every 0.68 molecules that's dissolved in the blood, one molecule is free to have an effect in the brain. So it's relatively available to act. The last keyword, the single breath induction keyword, was a good lead up to this topic, solubility and speed of induction. So the chart that I put over on the right-hand side there shows alveolar gas tension of various inhalational agents charted against time, which is the x-axis below. Now, what this shows is that solubility of gas is inversely related to the speed of induction. So if a gas has a higher blood gas partition coefficient, the rate of induction will be slower. And the lower the blood gas partition coefficient, the rate of induction will be faster. Examples that I put in below are that isoflurane has a relatively high blood gas partition coefficient of the modern inhalational agents at 1.4. This means that for every 1.4 parts that are dissolved in blood, one part is available to act on the brain in an undissolved way. The lower blood gas partition coefficient agents such as sevoflurane and desflurane have much less agent dissolved in blood and relatively more undissolved in blood that can act. Now, I can't stress this enough. You have to know these blood gas partition coefficient numbers. I've listed them below. Please just memorize them. First understand the concept, but also memorize the numbers. Desflurane is 0.42, sevoflurane is 0.68, isoflurane is 1.4, and nitrous is 0.47. These can be slightly different based on the source that you read, but this in general, these are the numbers that you should remember. Okay, we have succinylcholine and stroke, and I made this keyword a little bit larger. I said and large burns because this also comes into play as well. Basically, no. Just if a patient has had a stroke in any sort of way, the answer is no succinylcholine. There are some timing points over to the right, which I'll go over, but in general, succinylcholine is not to be given if a patient has had a stroke within the recent past or has sustained a large burn injury. Now, the problem with this is that patients are prone to hyperkalemia because extrajunctional acetylcholine receptors have proliferated throughout the body. This leads to a larger efflux to the extracellular space of potassium, and you can get a very, very high spike in potassium, much larger than the 0.5 that we would expect. Now, the timing of this doesn't last forever. Extrajunctional receptors tend to proliferate in a clinically significant sort of way between 24 and 48 hours after the injury. The effect tends to peak to a maximum in 7 to 10 days, and then these extrajunctional receptors stick around for quite a while. At least 2 years after the injury, some of these receptors will still be around. Now, this is mostly, it's not just stroke as in any sort of stroke. It's a significant stroke where patients tend to have some sort of functional deficit, which is what causes the extrajunctional receptors to proliferate. It's not necessarily just having a stroke itself. It implies that the stroke has affected the patient in a physical way. Our next keyword is alveolar dead space. Patients who are healthy as well as sick are prone to having alveolar dead space, although certain pathophysiologies will cause this to be more prolific. So this describes alveoli that are ventilated but are not perfused or poorly perfused, and ultimately do not participate in gas exchange, even though air is passing in and out of them. If you think about way back to medical school physiology, this describes zone of West number 1, where V outmatches Q, ventilation is greater than perfusion. In healthy adults, this is generally negligible, although stent can still exist in a very minor way. It becomes more significant with different pathologies. So, for example, with pulmonary embolism, clots do not allow proper blood flow through the lungs, and therefore, like you see in the picture over on the right, blood is not passing through the alveoli in order to participate in gas exchange. The same is true with advanced emphysema. The same is also true in decreased cardiac output states. So if less blood is flowing from the right side of the heart into the lungs, because of decreased cardiac output, less gas exchange is happening. Pneumonia and ARDS can also cause increases in alveolar dead space if the tissue has become proliferated so that gas exchange cannot occur. The lung may be getting blood flow, but the membranes may be too thick, or there may be fluid blocking proper gas exchange, which would also describe a state where alveoli were being ventilated, but not perfused functionally, and therefore not participating in gas exchange. So I started to see a trend here with some of our keywords. This is another calculation-based keyword. This is calculation of blood volume. So this calculation is based on gender, age, and BMI. And for different folks in each of these categories, there's tends to be a different volume of blood per kilogram. Blood volume is always described in a per kilogram basis. So for healthy adult males, the usual volume of blood per kilogram is 75 mLs. And in healthy adult females, it is 65 milliliters per kilogram. So adult males' total blood volume is generally slightly higher than adult females on a per kilogram basis. Now, as BMIs increase, more of the weight is due to adipose tissue, and therefore the estimated blood volume per kilogram goes down as the BMI goes up. Another important descriptor is in pediatrics. So with premature infants, they have the highest blood volume per kilogram. As children age, they have relatively less blood per kilogram. Term newborns decrease down to 80 per 90. Infants are usually 75 to 80. 1 to 12 years goes down a little bit further, 70 to 75, and it then sort of becomes that of adults. Now, this keyword is very important to understand because it lays the groundwork for quite a bit of cardiac physiology. So I'll go through this keyword in detail, even though the specific keyword from the exam was how cardiac pressure volume loops are affected by inotropy, but I'll go over what cardiac pressure volume loops are in general. So PV loops describe how preload, afterload, and inotropy ultimately affect cardiac output. The shape of a PV loop is altered based on the changes of each of these variables, and the cardiac output is described by the area of each of these loops. In general, to understand what each of these things represents, the right border represents isovolumetric contraction. The top right corner represents the opening of the aortic valve. The top of the loop represents ejection of blood out of the ventricle. The top left represents when the aortic valve closes. The left border represents isovolumetric relaxation. And the bottom left represents the opening of the mitral valve. After the opening of the mitral valve, the ventricle fills, and that is represented by the bottom border of the PV loop. Each of the variables here, preload, is the starting volume in the heart before a contraction. Afterload represents the pressure that the heart has to pump against, and inotropy is the strength of the contraction or the velocity of the muscle fiber of the heart shortening. Now, to make things even more challenging, each of these variables does not function in an isolated way. They're all related to each other, and so our pressure volume loops don't always look like the nice pictures that we have over on the right-hand side. The picture on the top left represents a change in preload. So as preload increases, that means that the heart begins to pump with a higher volume in the ventricle. So up to a certain point, cardiac output will increase until it gets to a point on that Starling curve where it falls, where the ventricle fails and it falls off. The middle image describes afterload, so that's the pressure that the heart is pumping against. As afterload increases, the heart has to pump more aggressively in order to eject the same volume of blood, and so the heart tends to operate with a higher volume in the ventricle throughout the cardiac cycle, and the pressure in the left ventricle tends to increase. The bottom left picture represents a change in inotropy, and rather than the loop shifting either higher or to the right, the strength of the contraction is changed. So the slope of the line that you see over to the left increases. It means that the pressure within the LV is changing in relation to volume more rapidly, and so with an increase in inotropy, you tend to have an increase in cardiac output. I hope this makes sense. It's like I said at the beginning, a topic that really requires you to know, to understand cardiac physiology in a complete way, and so please spend some time with this keyword. Our next keyword is coronary perfusion. Much like our last keyword, this comes up time and again. The heart gets its blood supply from several main coronary arteries. This is the left main coronary artery, which splits into two significant arteries, the left anterior descending, which supplies the anterior wall of the heart, and the circumflex artery. The right coronary artery, like it describes, goes around the right side of the heart, and in about 95% of folks, this right coronary artery supplies the PDA, posterior descending artery, which supplies the inferior wall. Coronary perfusion is dictated by coronary perfusion pressure. On the left side of the heart, this is described as systolic blood pressure minus LVEDP, left ventricular end diastolic pressure, and the left side is perfused only during diastole. On the right side of the heart, perfusion occurs mostly during diastole, but also some during systole, and this is systolic blood pressure minus RVP, right ventricular pressure. Our next keyword here is hepatic oxygen supply. It's a keyword that the board really loves to pull out and test pretty often. In general, the liver is supplied by two major vessels. These are the hepatic artery and the portal vein. The hepatic artery supplies generally a bit less blood flow, about 25%, but supplies 50% of oxygen to the liver. The portal vein will bring more blood to the liver, but about 50% of oxygen as well. Now, blood flow through the liver is extremely variable because the splanchnic circulation, as you see over in the image on the right, occurs first and then ultimately drains into the liver. So in high metabolic states or after a big meal, there's more blood flow in the splanchnic circulation and then ultimately less portal vein blood flow. The body compensates for this and makes sure that the liver continues to receive the oxygen that it needs for all of its activities by dilating the hepatic artery. It does this using buffers. This is also adenosine mediated. So when there is less portal vein tension, the hepatic artery will dilate and maintain the amount of blood flow and oxygen supply to the liver. Pretty interesting. Okay, our next keyword here is interpretation of blood gases. I couldn't begin to guess what the question on your test was targeting this keyword. This is a huge topic and a very important topic to understand because so much of what we do in the operating room with big cases is trying to keep homeostasis as in check as possible, and blood gases are a great way to make sure that we're doing this. I will just sort of briefly go over the components of a blood gas and how and why these various components are important. I would strongly urge you to copy and paste this link, or this, it's not a link, the URL down below, and go to this website. They have a nice way of going through blood gases in a systematic way that can really help you get the most information out of a gas as possible. So there are three main components to a blood gas. They tell us about oxygenation, they tell us about pH balance, and they tell us about sort of additional items, which include electrolytes, lactate, hemoglobin, other hemoglobin issues such as methemoglobin and blood glucose. So I'm not going to go into grave detail, like I said. Please go to this website. There's a nice step-by-step method that they use to help you get information out of blood gases, but it is a complex topic that I won't spend a lot of time going over right here. Okay, this keyword is law of Laplace. As you start to prepare for the basic and the ITE this winter, you'll see that there are quite a few laws of the physical world that the board expects you to understand and apply to the practice of anesthesia. And the law of Laplace is definitely one of these. So what this describes is wall tension as an effect of transmural pressure, the radius of the object that you're talking about, and of course wall thickness. This becomes clinically relevant in a couple of different ways. When thinking about the heart, you can talk about ventricular wall tension and how that contributes to myocardial work. In the lungs, you can talk about alveolar wall tension and how this can affect gas exchange. But ultimately what you need to know about the law of Laplace is that the wall tension equals the transmural pressure, which is the pressure across the wall, times the radius, divided by 2 times the wall thickness. That's the law of Laplace. There are so many good keywords in this second part of this presentation. This keyword is the relationship between SaO2, or pulse oximetry, and PaO2. Essentially, this is described by the graph that you see over on the right, the oxyhemoglobin dissociation curve. This will haunt you in your dreams, hopefully in a positive way. This will never go anywhere, so please, please, please take a good look. Get a good understanding of what this means and the different factors that shift this curve to the right and the different factors that shift this curve to the left. A rightward shift of the curve describes that oxygen offloading to tissues becomes easier. A leftward shift of the curve means that oxygen binding is stronger and the hemoglobin does not like to give up that oxygen. Now, there are a couple of key points in this curve that are important to understand and to memorize. One is the P50, which means the pressure of oxygen at which the saturation is 50%. Now, in a normal healthy adult, this is 27 millimeters of mercury. At a 90% saturation generally correlates with about 60 millimeters of mercury of oxygen. You can see this described a little bit over on this curve here. That, I believe, is what the keyword was getting at, but like I said, please spend a lot of time with this curve and understanding how the curve shifts to the right and shifts to the left and the different factors that contribute to that. All right, our next keyword moves into the postoperative area. So it is Aldrete score. So the Aldrete score is an assessment that's used to determine when a patient is ready to be discharged from the PACU area. It is based on 5 different items. These are activity, respiration, circulation, consciousness, and O2 saturation. Each one of these 5 items is graded a score of 0 to 2, and if a patient has a score of 9 or greater, that implies that the patient is safe and awake enough to be discharged from the PACU. Now, when you look at activity, it goes from not being able to move, which would be a score of 0, to the ability to move all extremities on command. Respiration goes from apneic to being able to breathe deeply and cough without difficulty to command. Circulation describes blood pressure, so we want the blood pressure to be as close to baseline as possible. Consciousness means that the goes from 0, where the patient is completely unresponsive, to a score of 2, which means subjectively awake. And oxygen saturation spans from less than 90% on supplemental oxygen all the way to at least 92% on room air. That always strikes me as being a little bit low, but that still gives you a score of 2 for oxygen saturation. Our next keyword is laryngospasm treatment. Laryngospasm, many of you have probably heard of as a feared complication of patients emerging from anesthesia. It's especially paid attention to up on the pediatrics floor because children tend to be a bit more prone to the laryngospasm. What it is physiologically, it's an exaggeration of the protective glottic closure reflex. The sensory input of this reflex comes from the internal branch of the superior laryngeal nerve. We talked about this a little bit in part 1. And the motor input of this is from the recurrent laryngeal nerve, which innervates the muscles of the larynx. The lateral cricoarytenoids, the transverse and oblique arytenoids adduct the vocal cords, and essentially these are stimulated and snap shut when stimulated. There are various risk factors that make this more common. Age, so young children, like I said, are more prone to this. Folks who have active or recent upper respiratory infections or have reactive airway disease tend to be more prone, and people who are exposed to secondhand smoke. GERD is a risk factor just because consistent regurgitation of acid into the posterior oropharynx can cause folks to be more at risk. So how do we treat this? The first step is recognizing that something's happening and that the patient is not moving air as well as you would like. The first step is to apply consistent CPAP with 100% oxygen using a tight-fitting mask. The temptation is to vigorously squeeze the bag and try to break it open just by forcing air through there. But we can allow the CPAP to do this in a better way by consistently applying pressure to the closed glottis. A vigorous jaw thrust often will help to open the glottis as well. We should definitely remove everything that may be causing the larynx to spasm. Usually this is either blood or secretions in the oropharynx. If at this point we have a branch, we have to assess how well we're doing just with giving CPAP. So if we are able to pass air, we can slowly come down on the CPAP. This describes a partial laryngospasm. We can then either continue to wake the patient up if we're able to pass air reliably, or we can deepen the anesthetic and let the patient go back off to sleep and try to bring them through that time period again. Stage 2, generally it's called, where the larynx is a bit more prone to spasm. If we are not able to pass oxygen or air, and the glottis is still closed, this represents a complete laryngospasm, and we should continue to try and pass air until we see that physiologically the patient is not doing quite so well. So this could either be by desaturation. If desaturation becomes significant, you may also begin to see bradycardia. We can, at this point, treat this pharmacologically. We can give a small dose of muscle relaxant, either Succinylcholine or Rocuronium. Succinylcholine acts a little bit more quickly, so this is generally preferred. And atropine to treat bradycardia, especially in peds if necessary. Eventually, this will break the laryngospasm, and we will try again. Our next keyword is PONV treatment. That stands for post-op nausea and vomiting. This is a very common problem. It affects about 1/3 of adults who receive inhalational anesthetics without any sort of prophylactic medication. And different folks have different risk based on a variety of factors. So there are patient factors. Non-smokers are more prone to nausea and vomiting. Female patients are more prone, and people who tend to get sick with motion as well. Opioids, inhalational anesthetics, and nitrous oxide have been shown to increase the incidence of post-op nausea and vomiting, and different types of surgery put patients at either higher or lower risk. So long surgeries tend to make patients more prone to nausea and vomiting, as well as GYN, breast, and other abdominal procedures. ear surgeries are snuck in there as well, just because when the inner ear is affected, folks can feel off balance and more prone to nausea and vomiting. So how do we either prevent this or treat this? So recommendations are that if patients have at least two or more of the risk factors on the left, they should be given prophylactic medications, at least 2 agents. And common agents are listed below, and they each combat different receptors that play a role in nausea and vomiting. So some of the more common ones that we use every day in the operating room are ondansetron and dexamethasone. Ondansetron is a 5-HT3 receptor antagonist, and dexamethasone is a corticosteroid. Some other less common medications include aprepitant, which works on the NK1 receptor system. Dopamine blockers have been used for a long time to treat post-op nausea and vomiting, as well as antihistamines and anticholinergics. All right, our next key word that we have is train of 4 and pharyngeal muscle strength. So train of 4 monitoring is used to assess muscle strength after administration of a neuromuscular blocker. The train of 4 ratio refers to the strength of the first twitch when you press the train of 4 button on the monitor compared to the strength of the fourth twitch. A ratio of at least 0.9, which ultimately means that there's very little difference between the first twitch and the fourth twitch, means that a patient is adequately reversed after administration of a muscle relaxant. So this is very important because if a patient has 4 twitches of any strength, that could mean that at least 70% of all acetylcholine receptors may still be blocked, and ultimately the patient may be weaker when you bring them out to the PACU than you would like. The next teaching point about this topic is that different muscles have different sensitivity to muscle relaxant. When you give a muscle relaxant, it doesn't treat all muscles the same. Laryngeal muscles have a quick onset and a quick recovery, which is wonderful. But what that means is that even though laryngeal muscles may be recovered from neuromuscular blockade, other very important respiratory muscles such as the diaphragm may not be recovered. So this is important, an important reason why we like to monitor train of 4 at the adductor pollicis muscle, which is a muscle along the forearm, along the ulnar nerve distribution. This has slower onset and slower recovery than other muscles, so you can be confident that most other muscles are fully recovered once the adductor pollicis muscle has been recovered. It's important to measure the train of 4 at this location because this also serves as the best proxy for the diaphragm, which is ultimately necessary to be fully recovered to avoid respiratory problems in the recovery area. Here we have ASA fasting guidelines. So this is a very straightforward keyword that the board can write some very complicated questions about. So we'll go over this in as simple a way as possible. So for any clear liquid, the recommendation of the ASA is to fast from clears for 2 hours. For breast milk in the realm of peds, the minimum fasting period is 4 hours. For any non-human milk, and including infant formula, the recommendations are 6 hours. A light meal is also 6 hours of fasting, although a light meal has different definitions. Most textbooks will describe a light meal as tea and toast. So a piece of toast is considered a very, very light meal. So if anything more than a piece of bread or a piece of toast has been eaten, that would fall under the umbrella of an 8-hour recommendation. So this includes fried foods, any fat-containing foods, or any meat product. And also any volume of food that is greater than a slice of bread. There's some other issues that come up. So clear liquids really comprise water, fruit juice that doesn't have pulp, any carbonated beverage such as Coke, tea, black coffee. If cream is added to the coffee, unfortunately, that is fat and is thought of as a fatty food. That is sort of where some of these questions can get a little bit confusing, is when they add in little details such as cream in the coffee. Another teaching point that comes up sometimes is chewing gum. If a patient comes in for surgery chewing a piece of gum, that's not considered a food or even a clear liquid. The ASA says that you can proceed with surgery if patients have been chewing gum. Our next keyword here is effects of preoperative smoking cessation. So again, the ASA is back with their recommendations. Patients should always be advised at any opportunity to quit smoking. Even though there are some times that are better than others, any time is a good time to quit smoking. The optimal time to quit is more than 4 to 8 weeks before surgery. The reason for this is that the small cilia within the respiratory tract can recover in this time and help to clear respiratory secretions. But if smoking cessation occurs before then, that's still okay. That last a little bit of recovery just may not have happened. So in the early time period of smoking cessation, 12 to 24 hours, carboxyhemoglobin concentrations come down. The P50, referring to that oxyhemoglobin dissociation curve, will shift rightward, which means that oxygen delivery ability is increased, which is fantastic. So even not smoking the day of surgery is beneficial. In 1 to 2 weeks, that mucociliary clearance will begin to get a little bit better. Within 3 to 4 weeks, there's some improvement in wound healing and improvement in complications related to that. And then beyond 4 to 8 weeks, all respiratory complications will decrease, and beyond that, there's an overall decrease in postoperative morbidity and mortality. So any time is a great time to quit, but here are some of the time periods that are most relevant. All right, this keyword is coronary stents and elective surgery. So this keyword will come up over and over and over for as long as you practice anesthesia. It's extremely important to stay up to date on these guidelines, as many patients undergoing non-cardiac surgery have coronary stents and take antiplatelet medications to prevent stent thrombosis. These guidelines are revised periodically to stay current with the latest stent technology and antiplatelet medications. So currently, for non-emergent cardiac surgery, patients receiving bare metal stents should continue dual antiplatelet therapy for a minimum of 30 days. Patients receiving bare metal stents should continue dual antiplatelet therapy uninterrupted for 6 months. If surgery is required within these time periods, that is to be done by interrupting antiplatelet medication, it really has to be emergent in nature, and the risk of not doing the surgery has to outweigh the risk of stopping the dual antiplatelet therapy. Along those lines, there is a line in the recommendations that states that if the risk of delaying surgery is greater than the risk of a major adverse cardiac event, known as MACE, when one of the antiplatelet medications is interrupted, surgery may proceed after 3 months. Another point at the bottom is that that's commonly tested is that if surgery is planned that requires interruption of Plavix or an equivalent antiplatelet medication, aspirin should be continued whenever possible. Okay, we're moving into regional and neuraxial topics. So the first one here that we have is contraindications to spinal anesthesia. So contraindications fall into two main categories. They're absolute, where if a patient has this characteristic, you absolutely cannot perform the procedure, and then relative contraindications, which is where you have to balance some other risks and benefits. So in the absolute category, we have patient refusal. If the patient says don't do it, you cannot do it. If a patient is allergic to the spinal solution that is to be injected, also an absolute contraindication. If there's an active infection at the site of spinal, no good. If patients have severe coagulopathy, you should not perform a spinal due to the risk of hematoma and ultimately nerve damage and or paralysis. Severe or critical mitral or aortic stenosis is an absolute contraindication. And also metastatic disease near the level of approach. Now, other relative contraindications include abnormalities of the spine. It may cause the difficult placement of the spinal, or it may cause the spinal to not cover completely where you're expecting it to cover. Previous spine surgery can sometimes make spinal anesthesia difficult. If the patient also has hardware in the spine, it may increase the risk of infection, but this is more a relative risk rather than, relative contraindication rather than an absolute. Active systemic infections, there theoretically could seed the meninges, although some data is that there's weak data there. And then fixed cardiac output states, also a relative contraindication. All right, our next spinal-related keyword is nausea during spinal anesthesia. So for those of you who've spent any time on the obstetrics floor, you'll see that nausea is unfortunately not uncommon when placing spinals. And the main risk factor that is associated rather with spinal anesthesia is hypotension. The issue with this is that after the local anesthetic is injected and the spinal block level starts to rise, the sympathetic chain begins to be blocked. The sympathetic chain runs from L2 to all the way up to about L1. And the more of a sympathectomy that patients tend to have, the more hypotension results. After some time, the perfusion at the chemotrigger zone, also called the area postrema, which is in the brain, sees less perfusion and ultimately leads to nausea. So for treatment of nausea after a spinal, the first thing to reach for is a pressor medication that will squeeze the blood vessels. So this is usually an alpha-1 agonist. Phenylephrine is usually what we go for. We will also sometimes hang phenylephrine infusions preemptively when planning a spinal anesthetic. You can also treat the sympathectomy with a sympathomimetic drug such as atropine or glycopyrrolate. All right, our final spinal keyword and final keyword of this whole review is subarachnoid block spread. So a variety of factors will contribute to how high a spinal travels after it is injected, and they're listed below. The first factor is baricity of the solution. This refers to how dense the injectate is compared to CSF. If it is a hyperbaric solution, that means that it's more dense than CSF and it will follow gravity. So a patient sitting up, the solution will drop down and the lower dermatomes will be blocked. Whereas if a patient lays down, it will start to travel up toward the head. And most of these spinals settle out in the mid-thoracic spine just because a supine patient, this tends to be the most dependent region. For those of you just starting out, a hypobaric solution means one that is less dense than CSF. They tend to rise when the patient is sitting. And an isobaric solution tends to concentrate around the level where it is injected. Hyperbaric solutions, which are the most common type that we use, are mixed with dextrose, which is what causes the solution to be more dense than CSF. A couple of other factors, so age. Blocks tend to spread higher with increasing age, likely due to the decreased volume of CSF total. Patient position after injection, so just like I explained, if you lay the patient down, a hyperbaric solution will start to travel up toward the head. The contour of the spinal canal will change. I explained that a little bit. Different folks with different shaped spines will tend to have blocks settle out at slightly different locations. Addition of vasoconstrictors will cause spinals to travel to different levels. Pregnancy, spinals tend to travel a little bit higher because with the gravid uterus sort of taking up a lot of room, the CSF tends to be a little bit compressed, and spinals tend to travel a little bit higher. Then, of course, the concentration of the solution, the dose of the solution, and the volume of the solution injected all play slightly different roles in how high blocks will travel. Okay, that's all I have for you. Thank you very much. I hope that you all learned a little something, and I hope that everybody puts in a lot of effort and does very well on the upcoming ABA exams. I'll talk to you all soon. Take care.